Good afternoon. Now we are going to start the post-lunch session of this symposium, and I would like to invite Dr. Dinush Dharmavardhana, consultant cardiologist, to give the lecture on an overview of cardiomyopathies. Over to you, Dinush.
Hope you all had a satisfying lunch. And today's topic for the next 30 minutes is going to be cardiomyopathy. So, what is actually cardiomyopathy? It's a word derived from Greek language. Cardio means heart, myo means muscle, pathy means disease. So, disease of the heart muscle. So, it could be functional or structural abnormality. And as you know, human heart has 4 chambers, 2 muscular chambers called ventricles, and embedded in the muscle is the conduction system. So in cardiomyopathy, due to various structural and functional abnormalities, the cardiac output is reduced, and it's usually associated with arrhythmias. Increased morbidity is due to low cardiac output and increased intracardiac pressures, and increased intracardiac pressures leading to congestion of the lungs and other organs in the body. So there is an increased risk of death due to cardiomyopathy, and there are inherited and acquired causes. So the commonest presentation of cardiomyopathy is heart failure, and then the arrhythmias or dysrhythmias. So mainly the arrhythmias and dysrhythmias are the ones which give rise to bad outcome or sudden cardiac death. So before talking about more about cardiomyopathy, we should know what is heart failure. Heart failure is a clinical syndrome associated with typical signs and symptoms associated with or caused by structural and functional cardiac abnormalities, resulting in reduced cardiac output or elevated intracardiac pressures at rest or during stress. In this slide, I have underlined the key words. So what are the typical symptoms? Usually breathlessness, ankle swelling, fatigue, tiredness. Those are the typical symptoms of heart failure. And signs are elevated jugular venous pressure, lung bases have crackles, and then dependent edema. So as we all know, heart is a muscular pump, mainly the ventricles. So it is made up of muscle. So what happens? Heart has 2 phases, that is systole and diastole. During systole, the muscular pumps, the ventricles, actively pump blood throughout the body. And during diastole, especially the left ventricle, draws the blood, oxygenated blood, via the pulmonary veins through the mitral valve. So either of these phases can get affected in cardiomyopathy, leading to increased intracardiac pressures, and then that pressure reflected back onto the pulmonary capillaries, causing increased pulmonary venous pressures. So when the threshold is exceeded, it can cause pulmonary edema. So this is how the diastolic failure causes heart failure. Again, during diastole, what happens? The relaxing ventricle actively draws the blood from the lungs via the pulmonary veins. So when the diastole is affected, that diastolic drawing of blood from the lungs doesn't happen, so lungs get congested and over a long period of time can cause pulmonary hypertension. There's a case scenario for you. 15-year-old schoolboy collapsed during athletic training, and he was quickly brought to the ED after resuscitation, and during the ED there was a systolic murmur, and they took an ECG. It showed some abnormalities. So he's awaiting echocardiogram for diagnosing the disease, and he's asked to temporarily stop training. So now we'll talk about the types of cardiomyopathy. In most of the literature, there are 3 types mentioned, that is dilated cardiomyopathy, hypertrophic cardiomyopathy, and restrictive cardiomyopathy. So rarest being the restrictive cardiomyopathy. Thank you. That's all right, thanks. But I have also included arrhythmogenic right ventricular cardiomyopathy as well, because in some cases this becomes an important type of cardiomyopathy. So dilated cardiomyopathy, you can see in dilated cardiomyopathy, usually all four chambers are dilated. You can see the mitral valve. The length of the mitral valve leaflets now not enough because the ring has dilated, so leading to poor coaptation. So in dilated cardiomyopathy, apart from having dilated chambers, they have valvular abnormalities as well. The hallmark is dilated chambers, usually all four. So when the chambers dilate, usually it causes thinning out of the muscle, and mainly the systolic function is affected. And there is valvular regurgitation, mainly the mitral valve, and pulmonary hypertension occurs in the advanced stage because of long-standing venous capillary and venous pressure increase. Dilated cardiomyopathy is reversible in some cases. For example, ischemic dilated cardiomyopathy, if you treat the ischemia, we see in practice that patients sometimes do remarkably well. In myocarditis, once the viral infection goes away, and if you treat them properly, the myocarditis gets better on its own. And then there is an important type called peripartum cardiomyopathy that is also classified under dilated cardiomyopathy. Usually these people do well, happens in like mostly ladies more than 30 years of age, multiparous, multiple pregnancies, pregnancy-induced hypertension or history of eclampsia. Those are the people who have high risk of peripartum cardiomyopathy. Incidence is about 1 in 3,000, mainly happens in the black population, but we see among our patients, our population, in our population as well. So you can see there are so many different causes. The outcome actually depends on the cause. So there are primary and secondary types. So primary type, usually there is no cause. Usually happens in, it runs in families, so it has a genetic origin. So secondary ones, commonest one being the coronary heart disease. So some people argue that dilated chambers happening in coronary artery disease is not actually cardiomyopathy because it's not a disease of the muscle. Actually, it's a disease of the blood vessels. However, it can be categorized as a secondary cause. So there are metabolic causes, diabetes, thyroid disease. In diabetes, the small vessels can get affected. In long-standing diabetes, small vessel disease can lead to dilated cardiomyopathy. Infections, most common ones are Coxsackie and dengue, usually temporary cardiomyopathy, and then the HIV. Alcohol, like people who take alcohol daily, almost daily, especially who don't pay attention to their diet, they are at high risk of developing dilated cardiomyopathy. And peripartum cardiomyopathy I talked about a bit earlier, and then the toxins such as cobalt, and then certain drugs like recreational drugs like cocaine and amphetamines, and also some of the medications used in cancer treatment. Nutritional deficiencies, especially the micronutrients like B1 and selenium, is known to cause dilated cardiomyopathy. So what are the symptoms? They have the typical symptoms of heart failure, dyspnea and fatigue and tiredness, and then limb swelling. And the signs, dependent edema in late stage of disease, low volume pulse most of the time, shifted effects due to left ventricular dilatation. They commonly have murmurs mainly due to mitral regurgitation. And they have third heart sound when the stage of the dilatation is high and the end diastolic volume is high, especially in the decompensated state. They have basal crepitations. And the diagnosis, the most useful investigation is the echocardiogram. In the ED setup, you can do NT-proBNP until the echocardiogram is done. But in Sri Lankan setup, we don't have that. So we always have better access to echo than the NT-proBNP. Usually there are ECG changes, especially if there is ischemia. Sometimes there are ECG changes in myocarditis, and sometimes the ECG changes resemble that of LV hypertrophy because the chambers are dilated. So the cumulative electrical impulses are, have high amplitude. So sometimes we do cardiac magnetic resonance imaging to confirm the diagnosis, especially if you want to differentiate ischemic dilated cardiomyopathy from dilated cardiomyopathy, you can use the gadolinium enhancement. There is a feature called late gadolinium enhancement. So coronary angiogram is done in especially people with dilated cardiomyopathy if you suspect ischemic heart disease, because if you correct the ischemia, their cardiomyopathy improves. So the treatment is the classical treatment of heart failure, that is triple therapy. What is triple therapy? That is ACE inhibitors, ARB as a one group, and the second group is beta blockers, and the third group is mineralocorticoid receptor antagonist. So ACE inhibitors and ARBs have a class effect because almost all of the ACE inhibitors do help in treating the heart failure. But beta blockers, they don't have a class effect. We have only 4 different types of beta blockers. That is nebivolol, the latest, and before that we had carvedilol, bisoprolol, and long-acting metoprolol. So since this is a brief presentation on all the types, I will quickly mention only the treatment strategies. So triple therapy and then ICD, intracardiac cardioverter defibrillator, as a primary prevention of death due to arrhythmias, malignant arrhythmias. So CRT stands for cardiac resynchronization treatment in symptomatic patient despite optimal treatment. You can implant, this is actually a pacemaker which tries to pace both the left ventricle and right ventricle. You can't directly access the left ventricle. So to overcome that, you access the left ventricular area via the coronary sinus. Then in the later stages, there's no improvement or no relief with the available treatment. Then you can use the devices like left ventricle assist devices, and the cardiac transplant is usually the last resort, which is not practically possible in our country. Second type is the hypertrophic cardiomyopathy. This is the most important cardiomyopathy causing death in the young people. Asymmetrical septal hypertrophy is the hallmark of the disease. Usually the LV function is normal, and they have reduced diastolic dysfunction. Due to the hypertrophy of the ventricles, usually the cavity is small. So the left ventricular cavity is very small, so it can't fill during the diastole. So the ventricle becomes stiff. Usually this has a genetic inheritance, autosomal dominant. Death usually occurs not due to heart failure, but due to the malignant arrhythmias like ventricular tachycardia and ventricular fibrillation. So there is a genetic abnormality causing pathology at sarcomere, causing myocardial disarray. So the clinical signs are present in most of the people. They have increased A-wave jugular venous pressure, double apical impulse. Those are very difficult to identify if you don't have enough experience. But you can hear ejection systolic murmur coming from the dynamic LVOT obstruction. And if there is a mitral regurgitation, you will hear the pan-systolic murmur. So you can hear a ejection systolic murmur or a hollow systolic murmur. Usually they have the fourth heart sound, which coincides with the atrial contraction. Most successful screening test is echocardiogram, and ECG changes are almost always present. The ECG changes are usually the features of LV hypertrophy. There are Q waves in the anterior lead. Sometimes there are features of left atrial enlargement. You can see lead 2 and V1 to diagnose left atrial enlargement, and then some people have atrial fibrillation. So their signs are as usual, like diastolic dysfunction, external dyspnea. They can get chest pain due to relative ischemia because they have thick myocardium, especially in the septum, and then they can get exertional syncope or presyncope. Presyncope means there is no loss of consciousness, but there is what you call a blackout. Syncope means there is a transient loss of consciousness. So the signs are low volume pulse, double apex, ejection systolic murmur because of the dynamic LVOT obstruction, left ventricular outflow tract obstruction, and they can also have a pan-systolic murmur due to mitral regurgitation. And this murmur increases with Valsalva maneuver and standing from the sitting position. So the diagnosis is almost easily done with echocardiogram, but there are some different types. Say there are some, sometimes the hypertrophy is uniform, so then it's difficult. Then you use special tools like speckle tracking and strain rates to diagnose this condition. Cardiac magnetic resonance images is very important, and some countries they do genetic testing. So the treatment is like of diastolic heart failure. It is different to dilated cardiomyopathy. You should avoid nitrates and diuretics to avoid dehydration and vasodilatation. If you increase the vasodilatation, the gradient becomes more, and if you dehydrate, again the gradient becomes more because the left ventricle becomes empty. So people should avoid extreme exertion and dehydration. And beta blockers and calcium channel blockers are often used. And in patients with atrial fibrillation, anticoagulation should be used for stroke prevention. Surgical myomectomy is an option, but it should be done in a high volume center because it needs quite a number of volume for the surgeon to become very adept at doing this surgery. Alcohol ablation is the same. It is an available option, but these two treatments are not selected as the first option. Some people need mitral valve replacement if the mitral valve regurgitation is severe. Pacemaker implantation and sometimes electrophysiological studies are needed. So third type, which is the rarest type, it's called restrictive cardiomyopathy. The hallmark is they have very hard or stiff left ventricle and right ventricle. And usually the chambers are normal because the ventricles are so stiff they can't dilate. But the atrial walls are normal, so they dilate. So they have biatrial dilatation with normal LV and RV dimensions. So they have severe diastolic dysfunction. The hallmark is actually they have very low tissue velocities. If you know, tissue velocity means the ventricular walls contract very slowly. So that is why they get severe diastolic dysfunction. The commonest causes are sarcoidosis, hemochromatosis, and sometimes radiotherapy. And scleroderma is also known to cause cardiomyopathy, which is very rare. Just yesterday, I saw a probable patient with scleroderma cardiomyopathy, still not confirmed, but all what I want to say is that although it's rare, we can still see them. And some cases, they are idiopathic then, your outcome is very poor. Because if you have idiopathic restrictive cardiomyopathy, you don't have a primary cause, secondary cause to treat. So they usually go through the natural history of the cardiomyopathy and die. But if you have a cause, for example, sarcoidosis, you can treat the sarcoidosis and then cardiomyopathy can improve. Hemochromatosis is the same. You can do the iron chelation. And then, those are the amyloidosis, you can use chemotherapy. So if you have a cause, you can hang on to that and try and treat it. Otherwise, idiopathic ones have very poor prognosis. The symptoms are slightly different from the other two because they develop body swelling and abdominal fullness and dependent edema much quicker than the other types. They get tiredness and fatigue as usual, but if someone has more ascites and more dependent edema, elevated JEP with heart failure symptoms, and you do the echo, chambers are normal, atria dilated, either you are dealing with restrictive cardiomyopathy or constrictive pericarditis. I won't talk about restrictive pericarditis because that is outside the scope of this topic. Weight gain or even weight loss. Weight gain is due to edema. Sometimes they lose weight due to loss of muscle mass because of anorexia and low cardiac output. The signs are they have dependent edema, ascites with enlarged liver, sometimes tender, elevated JEP with rapid X and Y descent. They have steady pulse, and the third heart sound may be present. And of course, they have crepitations in the lung bases. So diagnosis is by echocardiography. They show dilated atria, normal LV function, severe diastolic dysfunction, and markedly reduced tissue velocities. And you can use other things like, you can examine the inferior vena cava, and you can do various other methods to diagnose. And then you can do the cardiac magnetic resonance imaging, and sometimes endomyocardial biopsy to definitively diagnose what type of disease is that. The treatment is to treat the underlying cause if there is one. But if you don't have a cause, usually they have very poor prognosis. Here, the usual treatment of heart failure should be used with with a lot of caution. Beta blockers and calcium channel blockers can be used. If you use ACE inhibitors, you have to be very cautious because they can cause profound hypotension. And diuretics are used for symptom relief. Sometimes they need anticoagulation for stroke prevention, especially if they have atrial fibrillation. Sometimes pacemaker implantation needed because the cardiac conduction system can get affected because of the infiltration. cardiac transplant is the last resort. So the last type is the arrhythmogenic right ventricular cardiomyopathy. It is a primary disease of the heart muscle that results in fibropathy, replacement of the right ventricle, and also the subepicardial region of the ventricle. Usually they first show the abnormalities in the right ventricle, but you know that it can also affect the left ventricle. Etiology is unknown. It has a genetic involvement. Most patients have biventricular involvement, but you don't overtly see that. Development of heart failure and malignant arrhythmias cause the morbidity and mortality in these patients. So, symptoms, palpitations, they develop pre-syncope and syncope due to aborted cardiac arrest or like ventricular tachycardia, ventricular fibrillation, and heart failure symptoms develop in the advanced stage. The signs, there are no specific signs in this disease, in this cardiomyopathy, and the diagnosis depends on the screening with echocardiography. Magnetic resonance imaging can establish a diagnosis and histology when required. There are famous personalities afflicted with this disease. Recently, if you may know that one English cricketer got diagnosed with ARVC and he had to give up his cricketing career at a very young age. He was a very promising cricketer. So you have to stop exerting, otherwise it increases the risk of arrhythmias. So the lifestyle changes. Beta blockers can be used, especially you can use sotalol, which is an antiarrhythmic agent with beta blocking properties. ICDs are used to prevent sudden cardiac death, and cardiac transplant is as the last resort. So I tried to cover the broader areas in this topic, and the thing to remember is that cardiomyopathy is usually causing heart failure, but each cardiomyopathy is different to one another. For example, dilated cardiomyopathy is the closest to the usual ischemic heart failure that we see. Other types like hypertrophic cardiomyopathy and restrictive cardiomyopathy, they predominantly have diastolic dysfunction. So in diastolic dysfunction, as you may be aware, there is no evidence-based treatment. You can only extrapolate that the treatment for systolic heart failure can help. So thank you very much.
Thank you, Dinesh, for that very interesting and very extensive lecture on cardiomyopathies. May I invite you to the panel over here? Until we get the questions from our online viewers, can I ask a question? Is pregnancy advisable in all these conditions, or are there any contraindications for pregnancy in cardiomyopathies?
Usually in most of these cardiomyopathies, pregnancy is relatively contraindicated. Yeah. But say, for example, if a patient has a history of peripartum cardiomyopathy and the patient fully recovers and the ejection fraction is normal, and if patient wishes to get pregnant, it is not a contraindication. But in most other conditions, it is advisable to practice permanent contraceptive method except hypertrophic cardiomyopathy.
Yes, unless if there are no LVOT obstruction.
Hypertrophic cardiomyopathy is different, depends on the left ventricular outflow tract obstruction, the degree of the hypertrophy, and the history of arrhythmia and all that. So except for hypertrophic cardiomyopathy, in almost all other conditions, pregnancy is relatively contraindicated.
Thank you.
And Dinesh, now when it comes to the family screening with regard to these cardiomyopathies, is there any age limitation for this? Because usually we have seen there are some children also coming with HOCM, that is hypertrophic cardiomyopathy. So do we have any recommendation for the age?
Actually, to be honest, I actually don't know exact age limit, but in practice what I practice is that I get them to undergo screening when they're at least 15 years. Otherwise, it's too early. Yes. Usually, malignant arrhythmias and that sort of things happen very rarely less than 15 years.
Thank you, Dinesh.
We don't have any questions from online viewers. I'm not sure whether they are have fallen asleep after lunch. Anyway, thank you so much, Dinesh, for your contribution.